Perfect. All right, so welcome. This is our fetal alcohol syndrome presentation. And I'm going to introduce Lou. So Louis Bartoshesky has a BA, MD, MPH, MALS. And I only had to look up 2 of those to figure out what they meant. But Lou was born in Delaware, which is now the Wilmington Hospital. He's a year behind Joe Biden at high school at Archmere. He has a Bachelor's of Arts from Notre Dame. He has a medical degree from Cornell, Master's of Public Health from Harvard, and a Master's of Arts and Liberal Studies from University of Delaware. So highly educated, lots of schooling. He's a clinical geneticist with a fellowship at Tufts, certificate in pediatric bioethics, sorta, kinda, semi-retired, and he's happily received 2 doses of his COVID vaccine. So Lou, I'll turn it over to you.
Thank you.
I'm going to share your PowerPoint here so we can just dive right into it.
And you'll advance them, or do I advance them?
Yep, I can do it. All right, go for it.
Okay. So before we get going too far, let me tell you, I sent something to Lauren the other day. The CDC, the American Academy of OBGYN, the American Academy of Pediatrics, Family Medicine, they all recommend that women who are pregnant or planning a pregnancy not drink at all.
Sorry.
So the fetal alcohol syndrome is the name that was given in the late 60s, mid 70s, and then there are other names that have come up along.
Was that recently?
Hey, I'm gonna make sure everybody's muted. If everybody can make sure they're muted. All right, sorry, Lou, go for it.
It was called fetal alcohol syndrome at first, and I'll give you a little more history in a little while. But then care providers were seeing kids who behaved a little bit like fetal alcohol and looked a little bit like fetal alcohol, and they weren't sure if they had it or not. So some people use the term partial fetal alcohol syndrome. And then there was a population of people who were in their teens and adults who didn't have any of the features of fetal alcohol syndrome, the clinical features, but who were known to be exposed in the uterus, and they had neurodevelopmental disorder. So the term ARND came up, which is rarely used. ARBD is alcohol-related birth defects, and that would include in an infant who was exposed, a child who has, say, a hole in the heart or certain physical features, but does not have the behavioral developmental features. That became known as alcohol-related birth defects. And then after fetal alcohol syndrome had been around for a while, and somebody invented the term fetal alcohol effects, and that was a baby who had some exposures, had some features, but did not have the full-blown syndrome. So that was sort of the same as PFAS. And it's generally agreed now that there's too many terms, and fetal alcohol syndrome, fetal alcohol spectrum disorder is the term that's preferred now. CDC uses that term, and I think that's a term that would be worthwhile using, because it uses the word spectrum, which would therefore allow you to include people who had many of the physical features, but not the developmental features, or vice versa. So fetal alcohol spectrum disorder is perhaps the best term to use. Okay. So I took one definition from Wikipedia: a group of conditions that can occur in a person whose mother used alcohol in pregnancy. Fairly simple. By the way, Wikipedia has a nice entry on this topic. I know Wikipedia has its critics, including me, but sometimes you get good information out of there, and it's a good place to start for this topic. It's got a lot of references, and Wikipedia also has a scholar option. No, that's Google, isn't it? Anyway, Wikipedia is a good place if you want to look at this. And then a more formal definition: a cluster of birth defects occurring due to prenatal alcohol exposure, including growth restriction, craniofacial variations, and other structural variants, and intellectual disability. I picked the Canadian Medical Association because Canada has a healthcare system that's as good as ours if you're really, really sick, and not nearly as good, and ours is not nearly as good as theirs for everyday healthcare. So because Canada has universal health insurance, and so I picked the Canadian Medical Association definition. It's the same as the American Academy of Pediatrics: a cluster of birth defects occurring apparently due to prenatal alcohol exposure. So the prevalence, and you can look this up and you can find different prevalences. There's a bumper sticker going around that says 1 in every 100 persons. And the AAP, American Academy of Pediatrics, and the Canadian folks also assume that to be a reasonable estimate, that 1 of every 1,000 babies born in the U.S. has fetal alcohol syndrome or fetal alcohol spectrum disorder. Half of North American women use alcohol, including in the pregnancy, and about half of pregnancies are unplanned. That plus the number of births there are per year in the United States, 4 million, gives us a number of about 40,000 births a year who have fetal alcohol spectrum disorder, or can be argued to have that. The problem is there's no specific test for it, which comes back later. So it's a clinical diagnosis based on developmental features, physical features, and for 40,000 births per year is a pretty substantial number. It's maybe the most common cause of non-related genetic intellectual developmental disability, IDD. So 1 in 100, Down syndrome occurs about the same, Down syndrome occurs 1 in every 1,000 live births. If you lump a bunch of perinatal issues together, maybe comes out to about 1 in every 1,200 or so. So 1 per 100 is an estimate that's reasonably developed and makes sense to most people in the field. 1/3 of children born to poorly controlled alcoholics will have FASD. So it gives you a different view of the disorder. But the poorly controlled alcoholic, what does that mean? I don't know. That's up for discussion as well. But some of the original papers that the mothers in question had were chronic alcoholics, and they admitted to that, and they acknowledged that they were drinking heavily during pregnancy. And that population of mothers, about 1/3 of the children will have FASD. Why do 2/3 not? We'll talk about that a little bit later, but that's an interesting, controversial question. Next. So there are reports in Socrates and Aristotle and other people in antiquity that sort of referenced the dangers of alcohol in pregnancy. And in the Bible, under Judges, there's a quote: "Be careful and drink no wine or strong drink in pregnancy." So somebody in 2,000 or more years ago suspected that alcohol during pregnancy could have adverse effects on the baby, and it made its way into the Old Testament, the Jewish Testament. 1752, a bunch of British physicians petitioned the House of Commons to take some action on the fact that there were effects of strong drink when consumed by pregnant women. So somebody in the middle of the early 18th century was suspicious about this. This is interesting, actually, because up until the last 100 years or so, it was believed by obstetricians, pediatricians, and other healthcare providers that the placenta was a very good trap filter. It kept bad things away from the baby, the fetus. But that proved not to be the case, of course. But that was the belief from years ago. But the British Parliament didn't agree with that. William Sullivan published a paper in the 19th century arguing that prisoners, women who were in jail in England, had a high rate of stillbirth, and he attributed that to the alcohol, with a justifiable conclusion to draw, but somewhat flawed. 1968 in France, there was a publication that said that stated that a review of number of cases, that there were a number of cases that these French physicians were describing who the mother was using alcohol daily, might be considered an alcoholic, and they noticed some adverse effects, statistically significant among babies. 1979, Sweden, there were some publications there as well, and that's where the name arose from. The Swedes like that term. Next. Believe it or not, the 2 American doctors who were really prominent in describing the syndrome were named Smith and Jones. I guess since Smith is the most common name in the U.S. and Jones is the second most common, why shouldn't there be a Smith and Jones? David Smith and David Smith, and I'll remember the other guy's first name eventually. Anyway, they worked together in a genetics clinic in Seattle, in Washington State, and they had a population of Native Americans who were alcoholics, and they got the first 10 or 12 babies that were seen by Smith and Jones, Kenneth Jones. They were able to associate these chronic alcoholic women, many of the Native Americans, not all, with a clinically describable syndrome. And they published a paper in 1978 about 250 cases. where they described some of the physical features as well as developmental and behavioral features in this population that they noticed. From the very beginning, it was clear there was heterogeneity here, that nobody had a good correlation of how much somebody drank compared as related to what the outcomes were. Even within families with same mother having two different children and having drinker in both pregnancies, one could be much more affected than one child than the other. So there was no substantial a clear-cut picture of what the syndrome was. But Smith and Jones, Dr. Dave Smith died not too long ago, and Ken Jones is still working, but they moved to Southern California. I guess they wanted the better weather. And that group of original cases described by Smith and Jones, some of them have been followed over the period of years, and we'll talk about their outcomes a little bit later today in the talk. So pretty widely agreed now, FASD is a preferred term. Anybody ever read Brave New World? Novel by Aldous Huxley. I guess I read it in high school. But in that book, Huxley describes a future that wasn't such a cool place to be, but in which all births resulted from an assembly line. And at the beginning of the assembly line, they would have an embryo, and they'd run it through the assembly line. All along the way, they'd add different organs to this developing fetus. And Huxley had a hypothesis, and Huxley described this process in his novel is that as the fetuses moved along this assembly line, they were destined to be alpha babies, beta babies, and down to epsilons. And the alphas were us, the college educated and so forth, and the epsilons were the people who weren't particularly intelligent and were in service at best, but frequently unemployed. And they were smaller than the A's and B's, and they had dysmorphic features, and they had intellectual disability. And Huxley's theory was, in his novel, that adding the alcohol to the assembly line was what separated the alphas from the epsilons. And I for some reason, remembered that when I learned about fetal alcohol syndrome X number of years later, and went back and reread it. And in fact, that's exactly what it did. Huxley believed that you could affect the outcome of the pregnancy along your assembly line by adding alcohol. And the more alcohol you added, the lower on the alphabet, alpha, beta, gamma, epsilon, the offspring would be. So next, please. So mechanism of malformation. Why should alcohol have an effect on a developing fetus? Well, the alcohol crosses the placenta readily. Placenta is a fence that keeps some bad things from the developing fetus. Things that are fat soluble, for example, don't get to the fetus very well. But alcohol passes right through the placental membrane, and the level of blood in a given mother while she's drinking is going to be about the same as the level of blood in her offspring, level of alcohol in her blood. So you would have hoped that the placenta would block the transfer of alcohol, but it does not. And the brain is particularly at risk for reasons that aren't totally clear, but they're not the only organ that are damaged. Now, the next bullet here talks about different processes that occur during normal brain development. The brain starts developing somewhere around 10 to 12 days after conception, and is in full developmental flourishing not long after that. And one of the important things that has to happen as the brain develops is the brain develops as concentric circles. And as the brain develops between 10 days and 10, 12 weeks, a whole population of cells that start in the middle of this concentric circle have to migrate, move out to the outside. And that's called neuronal cell migration. It's an essential series of steps that has to occur during the early and mid pregnancy. And alcohol seems to interfere with that certain neuronal cell migration. Alcohol also seems to block axons. Axons are the appendages to neural cells that reach out and join two neural cells together. That should be neurocells integration. And then the synapses is when two nerves touch each other and pass a message. And synaptic networks can be interfered with by alcohol during the developing stage as well. So a whole bunch of different things have been demonstrated to occur, primarily in mice. but paralleling the mice are the developmental patterns of the human. For many things in the body, the liver filters them out, but the liver does not does not an antitoxin for alcohol, and there are also a bunch of enzymes that are involved that are immature in the early gestation and then develop later, and these are enzymes that detoxify alcohol, and they're not present in large amounts in the early gestational period. As I said before, heterogeneity is still not clear how these features specifically result in the clinical features that we're going to talk about in a few minutes. Next. So clinical features, variability, and it's unclear how these are correlated. No one has been able to actually look at the dose of alcohol in the pregnant woman or the pregnant mouse and predict the specific outcome. You can predict from the amount of alcohol exposure in the mother that there's going to be some effect, but you can't be specific what that effect will be. Pretty widely accepted, however, in humans is that and in mice as well, is that there's growth failure. That doesn't mean the kids are, quote, dwarfs, close quote. They tend to be in the lower percentiles. And as you know, the normal birth weight ranges from 2,500 grams, so 5.5 pounds, up to 10, 12 pounds. But the mean, or the average birth weight in the United States is somewhere around 7 pounds, 4 or 5 ounces. And you can draw a normal bell curve for birth weight with babies. And the bell curve is moved to the left from 7.5 pounds to 6.5 pounds for babies with fetal alcohol syndrome. So many of them are still, quote, normal, close quote, height, length, and weight, but the average is lower than the average for the non-affected individuals. And the substantial, the low birth weight also is not necessarily predict how extensive the other features will be. Nothing predicts much reliably here in any area. So some of the features are listed here. 10th to 20 weeks of gestation is when the face is forming, and so the features around the face that are characteristic of the disorder are believed to occur somewhere between 10 and 25 or 30 weeks of gestation. Short palpebral fissures, ptosis, epicanthal. I think I have a picture. Next slide, I think, is a picture, isn't it? Next. There you go. This little guy, he's world famous. He was in one of the original papers by Smith and Jones, and the mother gave Smith and Jones permission to circulate this picture everywhere. So if you put in FAS on Google, this little guy's going to come up, and he has some of the features. He's a cute little guy, actually. And the typical pediatrician, family medicine doc, even geneticist, could walk by his bed in the nursery, or go and visit the mom and not be terribly struck by an unusual appearance. I hope you all agree with that. He's sort of a cute guy, but look carefully. His eyes slant down a little bit. So if you look at the face, look at the eyes, how the middle part of the eye is a little bit higher on the head than the lower part. So it's downward slanting palpebral fissures. Palpebral fissures are the fissure, or they go from one canthus to the other. The canthi are where the upper and lower lids join. The inner canthi are on the nasal side, the outer canthi on the outer side. So these, and the epicanthal folds are folds of skin over top of the canthus. And in this little guy, you can't really see in the two medial canthi. You can't see where the upper lid and lower lid come together because there's a fold of skin there, and those are called epicanthal folds. Those are also seen characteristically in people with Down syndrome. The palpebral fissures, the eye size, are said to be short in fetal alcohol syndrome. That means the measurement from the inner canthus to the outer canthus is less than that in the average child. Ptosis means droopy eyes, and you can get a little bit of idea, particularly in his right eye, well, I guess both eyes, where his lid is down over top of the color part of the eye and a little bit lower, and it's called ptosis. And then the bottom, the middle part of the face, the philtrum. The philtrum is the part of the face that goes from the nose to the upper lip. It tends to be smooth and flattened out, whereas if you look around the room to other people, most people have a little notch there, and these guys have it flattened out. And the upper lip tends to be thin. They call it hypoplastic vermilion border, the vermilion being the lips. And those are the main features of fetal alcohol syndrome that Smith and Jones, and before them, the French described. Make sense? Other features are described: congenital cardiac anomalies. Those are the only life-threatening ones. And even though the congenital cardiac anomalies are more common in babies with fetal alcohol syndrome. It tends to be VSDs and disorders that are readily dealt with surgically. VSD stands for ventricular septal defect, and the ventricular septal defect means a hole between the two large chambers of the heart. Remember, the heart has 4 chambers: left atrium, left ventricle, right atrium, right ventricle. And a ventricular septal defect is a hole in the wall between the two ventricles, right and left, and it permits blood to flow. That's blood that's in the left ventricle and supposed to go out to the body. Some of it short circuits across the ventricular septal defect and goes to the lungs. Those babies usually are not in trouble with birth. They can get in a little trouble at age 6 to 8 weeks, and usually frequently cures it, goes away by itself, but sometimes needs surgical correction. TOF stands for tetralogy of Fallot. Tetralogy means 4. Fallot was a French doc, and he described a bunch of babies who had a particular type of VSD, who had a displaced aorta, the main vessel carrying blood to the left side of the body, and thickening of the right side ventricular wall, and blockage of flow out of the heart. And those are the 4 things: tetralogy of Fallot. And that each individual things of types of heart disease can occur by themselves, but VSDs and TETs are the characteristic of the fetal alcohol syndrome babies. TETs usually will need cardiac repair, but they can usually be done later in the first year of life. There's an increased frequency of kidney anomalies, including a horseshoe kidney. There are minor lip variants seen in babies with fetal alcohol syndrome. This includes underdevelopment of the nails, differences in some of the creases, and sometimes some loss of range of motion in the fingers, so-called camptodactyly. So the pediatrician and clinical geneticist looking for fetal alcohol syndrome will examine the hands carefully, looking for differences in the nails and differences in the structure of the distal part of the fingers and toes. Optic nerve hypoplasia. The optic nerve develops throughout pregnancy, particularly in the second half, and this is one of the features that's a little more common in the late exposures. It's associated with requires usually a pretty careful examination by an pediatric ophthalmologist to prove it, because it's a matter of a subjective opinion on whether a nerve is underdeveloped or not. But it's not uncommon in people with fetal alcohol syndrome. It's not associated with specific vision loss, but overall does sort of vaguely associate itself with vision loss. Strabismus means lazy eye. Not at all uncommon in kids with fetal alcohol syndrome. On the other hand, not at all uncommon in the well baby nursery either. Cleft palates are seen, but not terribly commonly. And the neural tube defects are also seen more, but not terribly commonly, but increased frequency compared to the population in general. Neural tube includes spina bifida and encephalocele, serious congenital anomalies involving the grossly apparent in the central nervous system. The usual findings in the babies are more subtle and not as gross as neural tube defects.
Lou, we actually do have a question in our chat came in about is there any way to determine how much a mother consumed, how much alcohol was consumed by the mother?
The only way to know is ask her.
Okay.
There's a lot of research going on to try to answer that question. If you measure fetal alcohol in a newborn baby, if the mother hasn't been drinking for 48 hours, it'll be gone from the baby's blood because it's rapidly removed. There are some biomarkers that are being looked at. For example, it looks like alcohol is stored in the I block words down again. Anyway, meconium. There's evidence that meconium, alcohol gets in meconium, it can remain there, and so there's some research projects going on looking at the amount of alcohol and comparing that to the alcohol in the mother's blood in a cooperative woman. And then there's some biochemical markers that are overstimulated when there's a high alcohol exposure. So that's a clue as well. But the specific answer to the question is meconium showing some potential value to confirm chronic use, but measuring alcohol itself doesn't work in the baby. Gotcha. Now, the mother comes into emergency room in labor. And apparently, according to the examining doctors, think alcohol exposure is potential, and they can draw blood on the mother. But even if the mother has a high alcohol level, it doesn't mean she had a high alcohol level back at 10 weeks gestation or 16 weeks. So the answer to the question is not so hot yet.
Gotcha. Thank you.
By the way, my microphone sometimes gets covered up. So if I fade away a little bit, just say yo. And here's it. Oh, this picture didn't travel very well from Apple to the other way around. Lost some of the features. But anyway, this shows you an older child with the same features as the little guy before. What's missing here now is the epicantral folds are less dramatic because the nose is filled out a little bit. The eyes are short, however, and you can the upper lip is underdeveloped, filtrum is still flat, nose is short, and this again, if you took this picture and showed it to 10 clinical geneticists, probably 7 of them will get it right, and the 3 others will have some other explanation. So identifying and diagnosing fetal alcohol syndrome requires, or almost requires, a history of exposure at some point. So if someone never really didn't drink at all, baby can't have fetal alcohol syndrome. There are some syndromes in which the features are similar to fetal alcohol, but very subtle. Something called Dubowitz syndrome, for example. And some of the features are present, but those baby with Dubowitz syndrome are substantially disabled and have an intellectual disability. So again, the message is it's really hard to be sure about it. Next. The brain, we already talked about that a little bit. Pathologic features, axonal, the neuronal migration defects in the first part of pregnancy, we talked about a little while ago. In answer to your earlier question, is there a dose response curve for alcohol? Dose response curves are commonly done in laboratory animals looking for whether a given drug helps a given disorder or not. And dose response curve will be a x-axis and a y-axis, and we'll have a line saying at this dose, the likelihood of a cure for the strep throat, say, is such and such. And those response curves are well worked out in many areas. But efforts to, however, generate a dose response curve in alcohol have not been successful. There's some success in looking at mice and measuring the alcohol very carefully throughout the pregnancy, comparing the likelihood of an abnormal feature with other mice, but that doesn't translate exceedingly well to humans. So dose response curve would be nice, and it would, if there was such a curve, it would help answer the previous question about how do you know how much somebody took, but still being worked on. Now the Seattle people have published some papers pretty enthusiastic in how they're claiming that a given dose as admitted to by a pregnant woman does correlate with the degree of anomaly, but still, even though the syndrome's been around for 45, 50 years, still lots of uncertainty about that. Microcephaly means small head, and again, the average head size in a baby with unequivocal fetal alcohol syndrome is probably around the 10th percentile of the average head, which means some of the kids with microcephaly don't have microcephaly. Their heads looks like small normal. The more substantially affected kids will have smaller head circumferences. To give you an idea, the average head circumference of a healthy newborn baby is around 34 centimeters, whereas the average head circumference in development fetal alcohol syndrome is about 30.5 centimeters. So the heads are smaller, but because of distribution curves, some of them are in the normal range. We talked a little bit already about migration organization. First trimester, you're more likely to see structural anomalies, whereas alcohol use in the last trimester is not safe, but it's more likely associated with sophisticated things like memory, learning, executive function, emotional features, and so forth. So the brain is susceptible to alcohol from the time of conception, or at least 10 days after conception, throughout pregnancy, even to the last couple of weeks. There can be some effect, which is why the CDC and the ACOG, obstetrics and gynecologists, say that the best option is to stop using alcohol before you get pregnant, and don't use it until you're finished nursing. Next.
Gotcha. We actually do have one question. So are there any similarities with fetal alcohol syndrome that are also present in mothers who smoke while pregnant?
So I have a slide later that talks about possible confounding variables. And the answer to your question is no. Cigarette smoking has been correlated with a couple of things, unequivocally correlated with low birth weight. So a pack a day lowers the average birth weight, to about a pound. But as far as your more specific features, no. The cigarette smoking, if it has an effect on the nervous system, it's still been difficult to be clear about that, and there's no association with major structural anomalies with cigarette smoking. So smoking is a bad idea. It makes a baby smaller and may have some effect on increasing the frequency of cleft palate, may have some increased frequency of congenital heart disease associated with smoking, but you wouldn't confuse smoking with fetal alcohol syndrome. Now, there are some anti-epilepsy medications that are associated with birth defects. And one of them is not used much anymore, used to called Dilantin, has some of the clinical features about fetal alcohol syndrome. And so if you have a little bit of imagination, you could say, yeah, there's some similarity there. The babies who were post-anticonvulsants tended to be on the smaller side. They tended to have dysplastic, abnormally grown fingernails and toenails, increased frequency of heart disease, increased frequency of neural tube defects. But when you showed a picture of the little guy we showed before and compare that to a classic baby with fetal epilepsy, anticonvulsant syndrome, you wouldn't mistake the two for one another. We finished the other slide? Yeah, okay, next. Here's where it gets a little challenging because it came out smaller than I expected. I can make it bigger, I guess. Anyway, so can you see these? The headline of this slide is functional. And these are some of the features that have been described not in one particular paper, but in lots and lots of papers about fetal alcohol syndrome, hundreds are published every year. And the list includes things that are mentioned in at least 2 or 3 papers as interpreted by people who write collaborative papers. So learning difficulties, whatever that means, impulse control, social skills, abstractions, memory, judgment, attention deficit, communication disorders, and trouble with math. So that's a long list, and probably no baby has all those things, but a lot of babies who have classic fetal alcohol syndrome have many of these features, and some of the babies who fit in the spectrum disorder more comfortably can just have some of these. So the typical special education third grader who has fetal alcohol syndrome may have learning disabilities, may have some impulse control, might have very good social skills, may have attention deficit. So there's no one particular picture that fits all babies very well. So executive function, I guess executive function means planning out a project, setting up to do it, and then completing it. And kids with fetal alcohol syndrome aren't very good at that. They also tend to have poor social skills. Sometimes babies with fetal alcohol syndrome some observers will contend that they have some autistic features. Classic autism doesn't seem to be associated with fetal alcohol syndrome, although if you Google the two together, you'll find some papers that come up arguing that some of the manifestations of autism are maybe due to alcohol exposure. Not the main track in looking at autism, but it has been described in some papers as a possibility, something to look at. In cognition and sensory processing, kids aren't deaf. Well, there is some slight increased frequency of hearing loss and vision loss, but if those are taken care of clinically, there still can be some sensory processing difficulties. Speech pathologists will tell us that they can identify sometimes the kids are seeing for speech evaluations that the features are specific enough that the speech pathologists say this looks like it's fetal alcohol syndrome, and they'll call the docs and say, "Do you think this baby has fetal alcohol syndrome?" And sometimes they're correct. So auditory processing and visual processing disorders can be seen, and having one of those doesn't help you in third grade. And just back again. The cognition, so the current preferred term is what? Intellectual disability. Many people with fetal alcohol syndrome will have functional testing that will indicate that they could fall in the old category of mental retardation or mild cognitive intellectual disability. Not all, of course, again, as I said that 100 times already, but yes, increased frequency of cognitive function. Next. Am I talking too fast? So here's some disorders with names placed to them. Again, I took this from the Canadian study because they have some really nice follow-ups. ADHD, which you guys are well familiar with, I'm sure. Substantial percentage of people in the population have carried that label around, and a high percentage of people with fetal alcohol spectrum disorders fit in the category of ADHD too, or have features along those lines. They're not so good at foreseeing consequences. Again, it has to do with executive function again. Inability to learn from previous experience. There's one famous baby who was written up by his adopted parents, and they did their best they couldn't handle the kid, that he would hurt himself. Not a common feature of fetal alcohol syndrome, but seen at least in that few anecdotes. Immature behavior, poor organizational skills, again, executive functioning, and learning differences of all kinds. If you ask a school teacher, a special ed teacher, to give this talk, they would give you lots and lots of specific details about kids who have fetal alcohol syndrome. But they would also acknowledge that if the features, the list here are also seen in kids who have no alcohol exposure. So nothing specific about this list that relates to fetal alcohol syndrome exclusive of anything else. Next. Sort of a repeat here: impulse control, judgment, poor adaptability to change, language. Next slide. Treatment. It's a short slide. There's there's no specific treatment for fetal alcohol syndrome. There's some evidence that early identification of the syndrome, appropriate preschool program, in early intervention, and appropriate educational setting results in better outcomes. I think that's probably true, but making a diagnosis of fetal alcohol syndrome is difficult. One resource, American Academy of Pediatrics, says that typically the diagnosis is made between 8 months and 8 years. And if it's 8 years and diagnosis is made, that's a couple of years of ACEs, adverse exposures that can have long-term outcomes that are poor. So early identification is beneficial, but the only way to identify it is to be suspicious of it based on history. And women who are not necessarily always forthcoming with their amount of alcohol exposure that there was, and sometimes they just are not. Sometimes they're just denying it, not lying about it, just that they haven't acknowledged that they're drinking. Oh, I only have a couple of glasses of wine on weekends, or gee, do you think a one drink a month could really be harmful? I don't know, but the idea would be early identification is not as simple as it sounds. Some of these kids, when they're, say, given a Bailey score at 3 years of age, will have Bailey scores in the low normal range and won't be necessarily recommended for intervention. But in you guys, in your particular situation, suggesting that as an option, I'm not sure if you guys consider that your role or not. But you can't diagnose fetal alcohol syndrome without having an exposure. Next. That was a bit too dogmatic, that last sentence. If the baby has all the features of fetal alcohol syndrome and not just the spectrum, and hypothesis by the pediatrician, family doc, or geneticist about fetal alcohol syndrome could lead to more careful questioning of the partner, and the woman herself, or the partner. Why not 100%? Remember back in a previous slide, he said a third of the babies born to alcoholics out of control have full-blown syndrome. Why not 100%? Well, nobody knows what the dose is. If you're trying to give fetal alcohol syndrome to a mouse, you can measure up this amount of alcohol and shoot it into the pregnant mice. But in humans, the dose response, who knows what the dose is? I mean, how much do you drink, Mrs. Ty Cobb? Well, I drink. I have a nice drink of a glass of wine for dinner on weekends, and a couple of beers during the week. Well, did you really have a couple of beers, or was it during a week, or did you have a couple of beers every night? So the dose of that the fetus is exposed to is difficult to pin down. And again, I talked previously about these dose response curves. There's also a part of dose response curves, a threshold theory. There's a theory regarding that's applied to many different substances that can cause birth defects in humans. There's a theory that for many of these substances, a dose below a certain level, called a threshold, is not risky. But once the dose gets that's very nice, and that the people doing the mouse studies and the people in Seattle doing long-term follow-up believe that that's probably true, that there probably is a threshold, and there does seem to be a threshold in mice. A tiny dose might not be associated with any adverse outcome, but it's really hard to generalize that to humans. So threshold dose response, they also contribute to why not 100% are affected. There are genetic factors in the baby and in the mother that may attenuate the outcome. There are certain enzymes, and I think I mentioned this briefly a little while ago, that detoxify alcohol, and but those enzymes are not well developed in all babies. And even beyond that, there are some enzymes that are missing for genetic reasons, that there's a mutation in a gene that codes for these enzymes, but that enzyme is not that important in non-drinkers, but it's terribly important in the fetus being exposed to alcohol via the placenta. There are also some specific metabolic disorders. I have down here disorder glycosylation. Glycosylation is a process in which protein is produced in a cell, and then sugars are hooked onto it, glucose and sucrose, and then it goes out and does its job. And there's some congenital disorders, biochemical and metabolic disorders, in which the particular enzymes that take the glycosylated other enzyme and convert it to be functional, and those are rare disorders, and they explain only a minimal number of fetal alcohol syndrome babies, but they are an example of a genetic variation in the fetus and or the mother that can predispose to a higher risk for the fetal alcohol spectrum disorder. Alcohol dehydrogenase is an enzyme that's very important in the liver to detoxify alcohol in adults, but it can be overwhelmed. The alcohol dehydrogenases can be gigantically elevated, but just not doing the trick. So there's in the fetal alcohol spectrum disorder spectrum, these particular enzymes, you can find a correlation in a bunch of people have looked at a bunch of babies with fetal alcohol syndrome and gotten enzyme levels on the baby and on the mother, and did find lower levels of alcohol dehydrogenase, but not in a nice dose response curve and not reproducibly. And then some of the other enzymes that are important in the liver as well can predispose to why not 100%. And the last part about why not 100% is, well, the 1/3 that I quoted earlier, those are babies who had obvious fetal alcohol spectrum disorder, the 1/3 out of the alcoholic mothers, poorly controlled. But if you examine those babies very carefully and follow them longitudinally, developmentally, a bunch of them who did not have the obvious spectrum disorder at birth will end up having some of the features, some of the developmental behavioral features we've already mentioned. Next. So somebody asked about the diagnosis and biomarkers. So we already talked about blood alcohol, not a helpful thing to measure. Meconium, and also this looks like alcohol deposits in the hair sometimes. And so there have been some studies being done at babies being born who are exposed to alcohol. Parents have given permission to shave the head and looking for alcohol levels in the hair. It's promising, but not conclusive. Liver function, the heavy drinker or a binge drinker who continues the heavy drinking and binge drinking during pregnancy will often have evidence biochemically of liver disease, sometimes even to the point of cirrhosis, but certainly to fatty liver so if you're suspicious about a baby having fetal alcohol syndrome and the mother, you meet the mother and find out she is in fact has cirrhosis or has fatty liver, that's a supportive. Those are supportive data that make you think, yes, this really is fetal alcohol spectrum disorder. However, that's the exception rather than the rule. Next. So the previous slide said no treatment, and here's some examples of interventions, however. Stable and nurturing home. That's easy to say, but if a mother has a disease, alcoholism, it's not simple for her to say, I'm going to stop using alcohol. It's very difficult. It's a disease. You don't go to a person with asthma and say, stop wheezing. You go to a person with asthma with a plan of medicines to help the wheezing. So you can't just tell a woman who's an alcoholic, don't drink. She knows that. So the interventions are talking about a stable and nurturing home, difficult. Foster care, yes, maybe. Adoption sometimes, but this slide is kind of silly because everybody should have nice to have a stable and nurturing home. Early intervention program. So when the babies are identified early and can be started on the IEP programs early in life, and get therapy programs underway and develop good programs for the children up to 3, and then passing them on in Delaware from 3 to go to the school system and continuing to get kids in special education there and back all through school. Those babies / children will in fact have a better chance of a better outcome than those who don't have the interventions. On the other hand, sometimes the babies are identified early and given every intervention you can think of, and they end up with a list of disorders of functional and structural differences that are attributed to the alcohol. So it's not a happy picture. It's a difficult picture. Don't experience violence in the home. That's a good idea for everybody, but there's some studies that look at violence in the home in babies who were being exposed to violence when they were removed from the home had a better outcome. That's not specific for fetal alcohol spectrum disorder either, however. Some people have done some studies on the older kids, not the babies, but looking at music, art, and as being effective education. I think school teachers, special ed teachers will tell you that's true of a lot of kids, but maybe is more true of kids with fetal alcohol spectrum disorders than in the population in general. Next. Confounding variables. So what are variables? It sort of goes to the earlier question. What are things in life that could be confused with fetal alcohol syndrome or could contribute to its extent? So maternal health. We already talked about alcoholism, but other health issues in mother: poorly controlled diabetes, poorly controlled epilepsy, may be associated with increased frequency of developmental disabilities. That could be confused sometimes with fetal alcohol spectrum disorder, but not universally so. So maternal health can be a confounding variable, both in the fact that the mother may have liver disease herself, which makes it more difficult for her to be a nurturing mother. Somebody asked about cigarettes, and we talked about that briefly. But women who are alcoholics frequently smoke. They're not advised. It's not advised that smoking be therapeutic, but I've heard that in AA programs, substituting cigarettes for alcohol is maybe a satisfactory step to take in the eyes of some psychiatrists. Alcoholic women may be exposed to codeine, other opiates, cocaine, not necessarily, but frequently. So that somebody has an addiction disorder involving alcohol, they may have an addiction tendency also for other substances. In the 90s, there was all this talk about the crack babies. It turns out that in and of itself, cocaine is not a major cause of birth defects, and it's controversial if it's a cause of developmental disabilities. But clearly, the cocaine and exposure at some level puts babies at some risk. And so a woman, an alcoholic, also using cocaine may have a higher risk for adverse outcome or the spectrum disorder than the baby's exposed just to the alcohol. Next. The advice, by the way, is don't smoke. Don't drink if you can't help it. So this is a picture of two brains. The one on the left is a normal brain. The one on the right is extreme example of a chronic alcoholic woman whose baby had everything you can think of in a spectrum defect. And look at how small the brain is and how malformed it is. It loses all its folds. See all the folds on the brain on the left. Those folds develop early in gestation when the nerve cells migrate from one part of the developing brain to the other. And we talked about that. And this shows you a good example of that. The baby has depleted number of folds, and that's a feature that's seen in some babies with extreme fetal alcohol syndrome beyond the spectrum disorder. Next. Oh, I guess the exercise I put in didn't get done. Oh, I did have a few slides that, if I get my notes here, talking about adults and the young adults and adult adults. And the people in Seattle have done some long-term follow-ups, some of their patients that they were able to do, and they found a number of things. They found a third of these adults who were born with fetal alcohol spectrum disorder, up to a third have difficulty with drug use. The 25 to 50% of babies in this study, not babies, now adults, were homeless. Half the babies, adults in this study, had some interventions and interactions with the criminal justice system. The mothers and fathers who themselves had fetal alcohol spectrum disorders turn out to not have much luck with being parents themselves. Their executive function continues to be poor even into adulthood, and they have a high frequency of unemployment and loss of inability to keep jobs. There are some babies that were in this study, however, these adult studies in Seattle, who are doing perfectly well. They had had some educational difficulties, but they overcame them and turned out to be reasonably productive citizens. However, as I said a minute ago, the substantial percentage of these kids do have adult difficulties. So the papers about the adults, oh, here it is. That slide came up. How about that? Poor social skills, 35% have drugs, uncertain but likely homeless, and difficulty parenting, things like we talked about before. Is there another slide? Social skills, completing tasks. You see, this list looks extremely familiar, doesn't it? It looks like the same list as for the school-age children. And again, diagnosing in adults is even more difficult. Adults with executive function difficulties, interacting with the criminal justice system, having been in special ed, having dropped out, being homeless, none of those things contribute to becoming excellent parents. Although again, in some situations, with some proper support and some good luck, there have been some success stories in adults with fetal alcohol spectrum disorder. Diagnosing it in a 25-year-old would be very difficult. By the time that people are 25, they may be short, but not dwarfed. They may have any of this number of these disabilities we talked about, these neurologic disorders. But who would think of a fetal alcohol syndrome in a 25-year-old? Well, what's the advantage of even identifying it at that point? And that's an issue that ethicists have discussed. If you suspect fetal alcohol syndrome in a 25-year-old, is it ethical to pursue that? Because to pursue it, you'd have to interfere with another adult, that is the mother, and ask her about her exposures and so forth. So once the people with fetal alcohol spectrum disorder become adults, the interventions with the potential interventions are complex and difficult to prove their validity and efficacy. Next. So I do talk too fast, don't I? More questions? I think the I found something I emailed to Lauren. She'll send it out to you guys later. That it's from the CDC pamphlet, I think. That's a picture of a pregnant woman, and the message is don't drink if you're planning a pregnancy, or if you are pregnant. And if you are drinking and you're pregnant, stop. Some of these complex skills may not be as obvious in the women who stop and don't drink in the third trimester. So there's advantages to discontinuing the exposure to this substance throughout the pregnancy. Now, does that mean if you stop drinking today and you go into labor tomorrow, that you did some good for the baby? Well, you might have, because the baby wouldn't have a withdrawal syndrome then anyway. But basically, no. But there's good evidence to suggest that stopping is best. Now, some people believe there's a threshold under which it's safe. Yeah. Is a glass of wine twice during pregnancy, once on New Year's Eve and once on your birthday, is that going to cause fetal alcohol syndrome? Probably not. But you could have a good time without the champagne on New Year's Eve, for the benefit of the baby. And there was a lot of things on television recently where someone will be at a party and they'll say, "Have a drink," and she'll say no and look down at the ground, and they say, "Oh, you must be pregnant." So it is. Anybody ever seen that on a TV show?
I think I definitely have at some point.
Yeah. Okay. So questions, discussions?
I have kind of a general question. So our CASA volunteers are working with kids 99% of the time, in Division of Family Services custody. So, and they're living they may be not, they're not living in their homes, usually with their biological parents. So is there anything a CASA should know about kind of how to interact with a child that has FASD?
Not specifically. I think it's not unreasonable to expect a baby with this spectrum disorder to have remarkably difficult behavior. There are anecdotes about couples who adopted a baby in infancy with fetal alcohol syndrome who did everything you could think of correct, and the baby ended up in jail. Did they not do enough? Did they do well? No, they did all they could. But there's so much heterogeneity that's difficult. I think when you, as a CASA person, if your exposure interactions with the family, particularly the kids, the families, and the foster parents talk about behavior things, hurting themselves, some of the babies have lousy eaters in infancy, but nothing specific. But this condition is widespread enough, 40,000 babies a year, that it's worth bringing it up in the babies who are in care. That won't help the therapists a whole lot. But I alluded to a little bit a while ago that some things, some of the professionals, occupational therapists, speech pathologists, a lot of them say they get a clue from this, and they can develop a program for the baby that makes sense biologically. So the answer to the question is, like all the other answers today, is yes and no. But you can never diagnose alcohol syndrome unless you think of it. And I don't know what you guys, how much you get involved in the medical history or not, but there's a bunch of ethical issues around that as well.
In terms of sharing the information, or what do you mean?
Yeah. I don't know. I guess when DFS is involved, though, that those precautions still exist, though. Even a child in the care of DFS has a right to certain privacy, as do the parents.
So what I'm hearing is it's almost just most beneficial for CASAs to just be aware of what FASD is, and to acknowledge that if their child has some particular behaviors, it might be associated with that FASD. Not that they can do anything about it necessarily, but it's just helpful to know that might be where it's coming from.
I think you can make a case that you can do something about it. You can't cure it. But I think you can make a case that if you have a sophisticated physical therapist, occupational therapist, speech pathologist, social worker, early childhood educator, the people you guys work with, a lot of them will tell you that there are approaches that have been proven to be some value. Nothing curative, but there are occasionally some good outcomes. The 2/3 of who don't have the full-blown spectrum disorder at birth, even though they're a great risk, that's 2/3. And so they're certainly worth investing time and effort into those babies to give them every chance that they have. I hope I wasn't too gloomy about that, because I think that identifying the babies who might have this condition can be of some help in the short term, and also in the adults with the executive function disorders and so forth, there are programs available and for adults with disabilities that the therapists there might also have some experience with fetal alcohol syndrome or spectrum defect.
So it might be worth, if a CASA has a concern or a thought that fetal alcohol syndrome might be present, it might be helpful to kind of call a team meeting with the social worker, with any therapists involved, and maybe just kind of chat about it a little bit.
You might want to get a doc involved.
Okay.
There aren't very many people who specialize in fetal alcohol spectrum disorders. The kids who are suspicious for that usually are sent to geneticists, not because it's strictly genetics like PKU or Down syndrome, but because geneticists are trained to look for minor features that speak about major problems. And so if a CASA volunteer was suspicious in a 6-year-old, a pediatrician or family doc or developmental medicine specialist or geneticist might do some measurements of the shape of the eyes and look more carefully, take a photograph and look more carefully, or take a picture of a baby and share it with their colleagues and say, yeah, we think this might be fetal alcohol syndrome. The next steps would be investigating with the family. By the way, if it does turn out the mother acknowledges finally drinking, interventions for her are still available. And I suspect that there are some psychologists, psychiatrists, family therapists that will agree to take on families like this, where the mother has her issues, the father has his issues, the fathers are ticked off because the mother drank. My favorite case is a kid I saw as a clinical geneticist at birth, and then every year for 8 years. And at the 8th birthday, Dad said to me, how's he doing? Well, I said, he's doing okay. He's in special ed. He's doing well enough. His behavior's difficult, but not intractable. He said, well, you know, Doc, I never told you this, but my wife's an alcoholic. So it took 8 years to, and I, maybe I should have nailed it, but he was getting all the right services, but I felt stupid actually, because what happens is when you see the baby the first time with geneticists, one of our standard questions is, were any exposures in pregnancy? Specifically, did you take any anticonvulsant medication? Did you smoke? Did you use alcohol? Did you use any street drugs? Are you on opiates for any reason? Those are normal questions that the geneticists ask, and then they go into the family history. And we usually accept a yes or a no, rather, at that point. But if a baby comes in to see us in genetics and has on the smaller side and has ptosis, dysplastic fingernail, we say, gee, this looks like it could be fetal alcohol syndrome. And the way to pursue that, from our point of view, is to talk, frankly and confidentially with the parents.
Yeah, I think you're right. Like, it must be, I can only imagine how difficult it is in the beginning, because you're relying solely on self-admission.
Yeah, and I think I used a word like that as well. I try to avoid saying something would make the mother feel responsible. Now, she is responsible. That's an unfortunate fact of life. But being supportive in that situation will probably work better than being confrontational.
Wonderful. Does anybody have any questions before we wrap it up?
If I go over time, I under time.
No, Dr. Lou, you're great. This is perfect. So, well, I want to thank you for your time. I really appreciate it.
See you in a couple of weeks, right?